It's July 1st, you've got the pager, and your first call is a bad one. You've got an inpatient upstairs whom you've never met, and the nurse tells you he's pale, he's sweaty, and his blood pressure is 60/40. What are you gonna do? This video is part of a series that will teach you everything you need to know about how to manage shock, so that when you get that call about a patient who is suddenly hypotensive, you'll know what to do. To start things off, we'll review how the circulatory system works. And when we're done, you should be able to describe and recognize the clinical manifestations of shock. You should also be able to explain generally how abnormalities in the circulatory system can generate different types of shock. Let's get into it. In the most basic sense, shock is what happens when tissues and organs just don't get enough blood flow. If they don't get enough blood flow, they don't get enough oxygen, and then the tissues start to die. You should be able to recognize what it looks like when blood flow is insufficient. For example, when the skin isn't getting enough blood flow, patients look pale and sweaty, and their cap refill is usually poor. When the heart isn't getting enough blood flow, it beats faster and patients get tachycardic. And when the brain isn't getting enough blood flow, patients can be confused and have an altered level of consciousness. So if you see any of these things when you walk into the room, you should immediately worry that your patient might be in shock, even before you see that blood pressure. Of course, the hallmark of shock is low blood pressure. It's not perfect, like you can have a normal blood pressure and still look pale and sweaty and be in shock, and you can also have a low blood pressure and be totally fine. So you still got to know those clinical signs. But if the blood pressure is 80/40, you can bet that everybody's going to pay some attention. One thing you may not have paid much attention to before is the MAP, or the mean arterial pressure. This is the number in brackets that comes up right next to the usual blood pressure numbers on an electronic monitor. MAP is kind of like an average between the systolic and the diastolic. There's a couple of different formulas for it, but it's usually something like 1/3 the systolic pressure plus 2/3 the diastolic pressure. MAP is supposed to solve that problem of what to do when the systolic pressure is really low, but the diastolic pressure is really high. Like, is that good? Is that bad? If you just look at the MAP, that kind of gives you an answer. If the MAP is over 65, we're probably doing okay. Blood pressure is related to two different factors: cardiac output and systemic vascular resistance. I'm going to explain this with a diagram. Your heart is supposed to send oxygenated blood via the arteries out to all these tissues and organs, and then the deoxygenated blood comes back up to the heart via the veins. Systemic vascular resistance is the resistance that blood encounters as it flows through the blood vessels. It's mostly determined by how contracted or relaxed those vessels are. For example, if the vessels are constricted and squeezing down tight, it might take a lot of force to get blood to fit through, so the resistance will be high. On the other hand, if blood vessels are relaxed and dilated, blood can flow through there no problem, so the resistance will be low. A healthy vascular system lives somewhere in the middle, with resistance that is just sort of moderate. Systemic vascular resistance is mostly determined by alpha adrenergic receptors. These are the receptors that bind catecholamines like epinephrine and norepinephrine. So if you have a lot of adrenaline circulating through your blood, you'll have a lot of alpha activity, and your systemic vascular resistance will go up. Cardiac output refers to how much blood the heart can pump out and circulate over time. Cardiac output is made up of heart rate and stroke volume is determined by preload, contractility, and afterload. Let's break this down a little bit. First, heart rate, and I think this is pretty self-explanatory. It's just the number of contractions that your heart can do over a minute. Every squeeze spits out a little bit of blood, and if your heart ever needed to get more blood circulating, it could just squeeze faster and then more blood would go around. Heart rate is mostly determined by beta adrenergic receptors. These receptors also bind catecholamines like epinephrine and norepinephrine, but these receptors are specific to the heart. So if you have a bunch of adrenaline circulating through your body, you'll have alpha activity in your blood vessels and beta activity in your heart. Increasing beta activity also increases contractility, which we said is another important component of stroke volume. Stroke volume is the amount of blood that comes out with every squeeze, and we said that you can change stroke volume by changing preload, contractility, and afterload. Preload is the pressure inside the heart just before it contracts. This mostly depends on the amount of blood filling up the heart. So if the heart is full just before it contracts, the pressure and therefore the preload is high. If the heart is empty, the pressure and the preload is going to be low. Contractility is the amount of force that the heart uses when it pumps. The heart can squeeze really hard with a lot of effort, or it can just squeeze gently with a little bit of force. Contractility is mostly determined by beta stimulation, but it also depends on preload. Muscle fibers can generate more force when they're really stretched out. So if we load up the heart with lots of fluid and increase preload and really stretch out those cardiomyocytes, the next squeeze is going to be a really strong one, much stronger than it would be if the heart wasn't as full. You've probably heard about this as the Frank-Starling mechanism. If we increase preload, we can increase contractility, at least up to a point. Stretching those muscle fibers beyond what they can handle can actually make things worse and ultimately decrease contractility. The final concept is afterload, and this refers to the pressure that the heart has to overcome to get blood out. This is mostly determined by systemic vascular resistance. You can imagine that contracted blood vessels with high levels of resistance are going to be a lot harder for the heart to push against than relaxed blood vessels with low levels of resistance. But afterload can also be increased if there's something obstructing blood flow or preventing blood from getting out of the heart, like a big blood clot or a stenotic valve. That's the circulatory system in a nutshell. When we talk about shock, we need to think about systemic vascular resistance and cardiac output. Cardiac output is determined by heart rate and stroke volume is determined by preload, contractility, and afterload. When blood pressure is low and your patient is in shock, one or more of those things isn't working the way it's supposed to. It gets tricky because they're all kind of interrelated, but in general, there are three big areas where the system can fail. You can have a problem with the tank, the pipes, or the pump. If the tank is empty, none of this works and we've got to fill it up. An empty tank is a preload problem. A problem with the pipes is usually a problem with systemic vascular resistance, and in shock, almost always the resistance is too low. If the pump is broken, we've got to fix it somehow. This could be a problem with heart rate, where the heart is beating too fast or too slow. And it can also occur when the heart is damaged or too weak and contractility is low. We also need to keep in mind that the pipe or the pumps could be blocked up somewhere. Maybe something is obstructing flow out of the heart, creating an afterload problem. Or maybe blood can't flow into the heart, creating a preload problem. That's how I want you to think. Take everything you know about circulatory physiology and store it in your brain as tank, pipes, pump. A patient in shock has a problem hiding in one of those areas, and we have different strategies for working on each one. In the next video, we'll talk more about these different types of shock, and we'll talk about how to use fluids, blood products, and different types of medications to treat shock. When you're ready, click on the next video, and we'll get started. See you in there.